Assalamu alaikum. Today with us Dr. Khurshid Khan, professor and fellowship program, stroke program of Neurology, University of Alberta Hospital. Thank you at all to share your knowledge with us, Dr. Khurshid. You can start now.
Okay, let me just first get my slides. Do you see my slides?
Yes.
Okay, and do you see this in the presentation mode? Can you see them?
Yes, we can see.
And is it in the presentation mode? All right.
Yes,
so
yes, Dr. Khurshid. We can see,
okay.
we can see.
You see the one that I am sort of pointing to, right?
Yeah.
Okay, great. Well, good evening, everyone. Thank you for inviting me to make this presentation. We're going to talk about TIA and stroke in young adults. Based on age, they can be classified in three categories: in infants, adolescents, young adults, and older adults. I'll be speaking about the young adults. The definition of young stroke is somewhat arbitrary because depending on different studies that you read, it could be 18 to 50 or 55 or 60. But nonetheless, that's the age group that we'll be discussing about. I'm not going to talk about the infants, adolescents, or the older stroke, although there's not much of a difference between old and young stroke when it comes to management, especially the common etiological reasons or causes that result in stroke. Now, the incidence of stroke does increase with age, even in the younger population. So you can see that in the early 20s, the incidence is 2.4 per 100,000, which increases to close to 33 when they get closer to the age of 50. Strokes can be classified broadly into ischemic and hemorrhagic strokes. Ischemic stroke is by far the most common type in young and in the older individuals. In the younger individuals, subarachnoid hemorrhage accounts for 30%, while the intraparenchymal hemorrhage is felt to be about the same in the old and the young. Now, as we all know, stroke is a very common condition responsible for high morbidity and mortality worldwide. And annually, 15 million individuals are affected by stroke. And out of this, 10 to 20% occur in younger individuals. The incidence of stroke has been increasing by about 25 to 40%, depending on which epidemiological studies you read, especially in the younger population. Now, there are differences, geographical and racial differences are there. The incidence of stroke is higher in low-income, middle-income countries, and also in the low-income segments of developed countries. For example, in USA, Black Americans or Hispanics, they present with higher incidence of ischemic stroke, or for that matter, also hemorrhagic stroke. And if you look at globally, there is a difference. In the European countries, the incidence is around 7 to 10 per 100,000, while in the sub-Saharan countries, it goes up to 100 per 100,000. Now, there are some differences. It depends on how the information is collected. So there may be some differences in ascertaining the information and the definition of young stroke, but we know for sure that there are some other genetic and environmental differences as well, which might account for this difference. And worldwide, the stroke does account for highest mortality, and this is also more common in low-income and middle-income countries. So if you look at this graph, there is no significant difference between the male and female gender up to the age of 45 or so. Then the graphs tend to separate, and in the Western countries, the life expectancy is much higher than developing countries. And after the age of 80 or 75, then the gross overlap, and then because the females tend to live longer here, then the incidence slightly increases in older population. The prognosis, obviously, functionally maybe slightly better in younger individuals because of the brain ability to recover or compensate for the damaged area, the plasticity. However, the burden of a stroke is still higher in younger individuals compared to the older individuals because of the young age and the number of years that they lose, number of years of productivity that they lose. And it is costlier in younger population and then older population. It's about sixfold much costlier. Now, the mortality still remains high, even in the young stroke survivors, even if they have survived well and are physically and functionally independent. And this is felt to be due to underlying cardiovascular risk factors that they may have, or undetermined factors. As we know that 30 to 40% of the time, the risk or the etiology may not be known in these individuals. So there are challenges with diagnosis in the young individuals, and that may often lead to delay in the diagnosis. And it could be due to lack of awareness on the part of the family or the patient himself or herself. Stroke mimics are also common there. And because of the young age, even in the medical, the physicians may not consider a stroke as the first diagnosis in these individuals. And sometimes the symptoms may cause a little bit of confusion, especially posterior circulation symptoms may lead to some difficulties, because oftentimes younger patients may also present with headache and seizure at the onset more than the older individuals, and that may pose some confusion. Now, we should remember that in up to 50% of the situations, younger patients, they may have an alternative pathology other than stroke. The common stroke mimics we should remember, and they are migraine, seizure, peripheral vertigo, for example, or infection of brain tumor. So one has to have a high index of suspicion to make an early diagnosis and institute an early treatment. Now, traditional risk factors are still the most common etiological factors that may lead to a stroke. And the 10 most common modifiable risk factors that we all know, and out of this, the 5 most common being hypertension, sedentary lifestyle, obesity, smoking diet, and also dyslipidemia. In younger individuals, we also need to add other potential risk factors or possible etiologies, which is migraine, oral contraceptive pills, pregnancy in the puerperium period, cardiac infection, genetic, and, as I said, undetermined factor is there in a significant number of individuals. So I'll just go through some of the etiological classification and divided into arteriopathies. So the common non-atherosclerotic arteriopathies, dissection is one of the most common in younger individuals. It involves either carotid or vertebral artery, fibromuscular dysplasia, which may lead to dissection, moyamoya, especially in the Japanese or the Asian population, this may be seen. Reversible cerebrovascular vasoconstriction syndrome can lead to a stroke, hemorrhage, ischemic stroke or hemorrhage, or even subarachnoid hemorrhage. Substance abuse is another important factor there. Vasculitis and intercentric lymphoma and radiation-associated vasculopathy. And then the bigger group comes under the rubric of atherosclerotic arteriopathy. Talking about dissection, it accounts for 20 to 25% of all the strokes in the younger individuals. In carotid artery, it affects the internal carotid artery 2 centimeters distant to its bifurcation near the C2, C3 vertebral level, as opposed to atherosclerotic disease where it affects the bifurcation, as we all know. And the vertebral artery is also affected, and especially when it enters the dura, and that is the most common site where it may be affected. The pathophysiology of dissection, oftentimes we find a history of trauma, which could be a very trivial trauma, but more often than not, there may not be obvious history of any form of trauma. Some authorities feel that there is some degree of trauma, but it is so trivial perhaps that it's not remembered by the patient. So we would consider that as a spontaneous. And then obviously connective tissue disorders like Ehlers-Danlos syndrome, especially vascular type 4, and this is due to collagen 3A1 gene mutation, Marfan syndrome, autosomal dominant disease, and as I mentioned earlier, fibromuscular dysplasia. Now, other factors are also associated with dissection, and they include infection, migraine, maybe the family history. If there are other members who have been affected, it may increase the risk by 6 times. Usually the recurrence is very low in dissection unless there is an underlying connective tissue disorder, and annual risk of uninvolved arteries 1% or less. The usual signs that we look for are ptosis, meiosis if internal carotid artery is affected, compression of cranial nerves may be involved, and especially from 9 to 12, and cause dysphagia, hoarseness, and hemilingual paralysis. This is as far as the bulbar symptoms are concerned, but then if it is causing a stroke, appropriate contralateral findings may be noted in these individuals. Treatment of a dissection. So in acute setting, if someone is presenting with acute stroke, the treatment will be the usual treatment of thrombolysis, or if EVT, thrombectomy facility is available, that can be undertaken. For secondary prevention, aspirin or clopidogrel for 3 to 6 months. The question often arises, is antiplatelet better than anticoagulation or vice versa? As we probably know, that the studies have not clearly demonstrated a superiority of anticoagulation over antiplatelet therapy. So most of us now use antiplatelets. Sometimes we may use dual antiplatelets. However, if there is thrombus in the artery, if someone has had recurrent TIAs or stroke-like symptoms, then an anticoagulation may be used, because there is some uncertainty with respect to if there is one treatment better than the other. Both treatment potentially can be used. Fibromuscular dysplasia is a non-atherosclerotic, non-inflammatory vasculopathy. It is a little more common in the female, and it may cause dissection or even artery-to-artery embolism. The common sites, the most common site is the renal artery in up to 70% of the cases, and extracranially, internal carotid artery is affected more than vertebral arteries. In some case series, it does spare the proximal part of the internal carotid artery. Intracranial arteries are not commonly affected as a result of fibromuscular dysplasia, and if one were to do a biopsy, it will show fibroplasia of the media of the vessel. And these are some of the different types of fibromuscular dysplasia, the most common being a string of beads appearance in 80 to 85% of the cases. The other form is the tubular formation. So one has to consider these potential differentials for this appearance on brain imaging. And then the focal diverticular, or sometimes it may appear like a carotid web. So these are some of the findings of different types of fibromuscular dysplasia. Then another condition is a carotid web, which is felt to be a form of fibromuscular dysplasia involving the intimal layer of the internal carotid artery. Again, it is non-atherosclerotic, non-inflammatory condition. It may cause a stroke. And with respect to management, there is uncertainty. Should they be only on antithrombotic medications, medical treatment like aspirin or clopidogrel, or anticoagulants, or one should consider a surgery or putting a stent in. The jury is still out there, but I think from personal experience, people will use either of the modality. If someone has had recurrent episodes despite being on optimal medical therapy, then stenting may be considered in these individuals. Moya, which puff of smoke on appearance on the angiogram that we see because of the collateralization of other vessels due to tight stenosis or progressively stenosis that goes on to become occluded. Basal arteries are involved, basal arteries of the circle of Willis, and then it leads to multiple collateral formation of these arteries. Now, the underlying pathology is still debated, still not very clear, but one thing we know that there is a progressive intimal thickening, and it is felt that perhaps it's non-inflammatory. Some studies, sort of people have talked about possibly some changes which may suggest inflammation, but this is not confirmed yet, as yet. And basically for the timing, it's a non-inflammatory progressive disease, and that's most common in the Japanese population and the Asians. Investigations are done to rule out other potential etiology, especially inflammatory causes. And you would do just a screening workup for stroke, for atheromatous disease as well, the lipids, etc. Now, it may cause a TIA, ischemic stroke, or intracerebral hemorrhage, or even subarachnoid hemorrhage. Treatment for stroke prevention, if someone has had an ischemic event, then antiplatelets may be used. But we should also remember that it may also increase the risk of hemorrhage. Surgical bypass is the treatment option if someone has a progressive symptomatic disease. And usually here, superficial temporal artery is anastomosed with a middle cerebral artery. This is a procedure that is done not very frequently, and it may carry some risk as well. So the first line of management is usually medical treatment. If that is a failure, then surgical intervention may be considered in these individuals, by someone who is well experienced in carrying out IC bypass surgery. Recreational drugs or substance abuse in younger individuals is common. Multiple different medications that we are quite familiar with include cocaine, amphetamine, other sympathetic mimetic medications, and cannabis. It may cause both ischemic or hemorrhagic stroke. Stroke usually occurs within a short time of its use, within 24 hours of its use prior to experiencing stroke. There are different mechanisms that it may cause stroke through. One is the vasculitic abnormalities that may be seen in the blood vessels. It may cause necrotic cerebral infarction directly from the drug use. It may lead to cardiac arrhythmia and endocarditis, for example, leading to necrotic brain infarction, cardiomyopathy, and it may also lead to accelerated atherosclerosis. Vasculitis, primary CNS angiitis is rare, but more often than not, it is included in our differentials whenever we encounter a stroke, especially in the younger person. Systemic vasculitis, Behçet disease, which may be more commonly seen as a compared to some other countries, especially in part of the world that most of the audience is attending today. Drug-induced, as we all already talked about, and cancer-associated vasculitis, and then infection-related vascular disease that may be seen. Some of the conditions which may lead to large vessel vasculitis, like giant cell Takayasu, polyarteritis nodosa in the medium size arteries, and Schuck-Strauss or Wagner's conditions cause small vessel vasculitis. The vasculitic workup, the definitive diagnosis comes from a combination of tests, including vascular imaging, biopsy. None of these tests provide 100% answer to the question. For example, catheter-based angiogram has a positive predictive value of 30%, but the biopsy has a higher positive predictive value. But again, when the biopsy is done, as a neurologist, as a stroke neurologist, we have to provide detailed information to our neurosurgical colleagues where to pick the segment from, or close to the lesion or from the lesion, most preferably. And then some of the blood work that you do, also you do serological investigations for HIV, syphilis, hepatitis, and other infectious etiologies. You should screen them for hepatitis and cryoglobulins, etc. And obviously, a CSF analysis is also done in these individuals. Just to share a case with you, these are pictures of transcranial Doppler. Here you see right MCA with a dampened flow in the MCA, little sort of distal from its origin, and then more proximally, slightly higher velocities compared to more distal, and then more proximally picking up the internal carotid artery, which shows a turbulent flow, very high velocity, suggesting that there is a stenotic lesion. And you do CTA, and we noticed that there was this loss of signal in the internal carotid artery, which corresponded to this one, and in the distal vessels, the dampened flow was noted. Conventional angiogram shows a very tight narrowing in this artery, which could be due to atherosclerosis, but it's a younger patient, I can tell you that. And there is probably vasospasm. And to differentiate whether this is a vasospasm atherosclerotic disease, we went on to do an MRI, which shows this vessel wall enhancement, suggesting that inflammatory condition. And this was a case of vasculitis. Another condition that is well known is reversible cerebral vasoconstriction syndrome. It presents with stroke, ischemic stroke, hemorrhage, subarachnoid hemorrhage, and thunderclap headache is a prodrome that they often present with, more often than not. And geography may show multiple areas or one segment narrowing. Now, this is reversible, and after 3 months or so, you do the imaging, vascular imaging, and it would have reversed, as opposed to vasculitis, which will continue to progress. The treatment is usually empirical, and we use calcium channel blockers and control the blood pressure, and it generally has good prognosis. To differentiate from CNS vasculitis, they present with thunderclap headache, while here they may have an indolent insidious progression of cognitive decline, headache, and a progressively getting worse. So that would be a clue to consider CNS vasculitis as opposed to RCVS. It is important to differentiate this, and this is through history and examination, because there is no role for steroids in the RCVS. And some studies have shown that RCVS steroids may lead to bad outcome in the RCVS. And the factors that may cause RCVS would be pregnancy, vasoactive drugs, cannabis, some antidepressants may also lead. So those preceding events or medications, history is very, very important in these individuals. Now move on to some hematological etiologies. Sickle cell disease, which is common in Africans. It over time leads to vasculopathy in the cerebral arteries. TCD studies have shown that it may be used to predict the individuals who may be at high risk because of the vasculopathy. There is increase in the velocity. So oftentimes this may be used, especially in children, to monitor their status, to provide them with frequent blood transfusions. We have done this. Our hematology colleagues have asked us to do TCD in these individuals, and then the TCD can help them to determine how often the blood transfusion is given to these individuals. Cardiac causes, these are, I think, probably among the top 3 or more causes: dissection, cardiac, and in female gender, pregnancy, or oral contraceptive medications, purpurium, for example. And those are the 3 main top causes, and then obviously undetermined etiologies. So this includes various different possibilities. Atrial fibrillation, which is not that common in the younger population, but one must consider this and do prolonged monitoring if the index of suspicion is high. Cardiomyopathies, rheumatic heart disease, there is a high prevalence in the developing countries. One must consider this. Endocarditis, especially in the IV drug abusers, or it may occur otherwise as well. PFO, patent foramen ovale, cardiac tumors, myxoma, and congenital heart disease, and then cardiac arteriopathy. So this is another important entity that is being recognized more frequently now. So with respect to patent foramen ovale, it has a general prevalence of 25% in the general population. It is not usually considered a high-risk entity for stroke. But in cryptogenic stroke, where you don't find any other obvious cause, then we look for PFO. And it has been shown that in young individuals with stroke, the incidence or the prevalence of PFO is more than 50%. The cumulative risk may be high in individuals who have cryptogenic etiology for a stroke. So it is important that we very carefully and methodically look for other causes. PFO can be diagnosed by an indirect way using transcranial Doppler, in which we inject agitated saline, creating microbubbles, and look for microbubbles on the TCD. But the definitive test comes with echocardiogram, transesophageal echocardiogram, which gives more information with respect to the size of the PFO, if there is intra-atrial septal aneurysm, etc. So that information will be obtained with echocardiogram. This is again a TCD picture showing these multiple bright microbubbles after. So this is a normal cardiac cycle, and once the agitated saline is injected, within a very short time, within 3 cardiac cycles, we begin to see multiple emboli, suggesting a right to left shunt, most likely a PFO, because it occurred within a very short time of injection. So next question is, if this is found to be the possible paradoxical cause of stroke, what do you do with that? Do you close it, or do you just use medical treatment? Only in selected patients, based on multiple studies, under the age of 60, a closure may be considered for cryptogenic stroke. In those who have high risk anatomical features, and as I mentioned earlier, someone has right to left shunt, felt to be due to PFO. There is arterial septal defect. There is large right to left shunt, and this will be determined by number of microemboli that we see, microbubbles that we see, and the size of the PFO, which is felt to be larger than 2 millimeters. Then closure may be considered if you have someone who is well experienced in performing and those percutaneous closure of the PFO. With respect to the procedure itself, there is a risk of atrial fibrillation, which is approximately 4 times higher at the time of procedure. And I don't think this has been shown to be a long-term effect. Now, for determining who may be a better candidate for PFO closure, people have proposed a risk of paradoxical embolism score. So the higher the score, the higher the likelihood that PFO was a contributing factor or was the cause of stroke. So there is no history of hypertension. Basically, what we are trying to do here is to rule out other conventional vascular risk factors or etiologies. So 1 point is given for no hypertension, no diabetes, no prior TI stroke. The person is non-smoker, and the person has cortical infarcts on imaging, and age. If it is a young person, for example, you get 5 points for 18 to 30. And if you take this one and these 5 points, 10 is the maximum point. And the studies have shown that 7 and over, or more than 7, the score on row scoring system will suggest that the PFO was the likely cause, and that individual may be considered for closure. If a person is not a candidate for closure, then antithrombotic medication can be used. And again, the question arises, anticoagulation versus antiplatelets, and there is uncertainty about this question. There might be some signal that anticoagulation may be better in some of these studies in subgroup analysis, but this hasn't been looked at in a sort of randomized fashion, specifically antiplatelet versus anticoagulation, with the question of whether PFO closure versus antiplatelets, and which antiplatelet may be better. So we tend to use antiplatelets in those individuals who are not candidates for for closure. Hypercoagulabilities. Inherited thrombophilia, as we all know, protein C as factor V laden, antithrombin 3, and prothrombin G2021A mutation. Now, this screening is only needed in individuals who have clear history of family of stroke, miscarriages, or someone has lupus antibodies or lupus anticoagulant. Miscarriages would be higher on the female gender side, or recurrent clotting abnormalities, etc. Otherwise, this should only be done in a very selected fashion. Acquired hypercoagulabilities due to cancer or due to hormone use, and paroxysmal nocturnal hemoglobinuria is a very rare cause of stroke, But one should consider if someone is presenting with dark urine in the morning, for example, it's not that the hemolysis occurs only in the night, but it's, in the night, the urine sort of accumulates in the bladder, and that's where there is a dark color of the urine in the morning. This will be investigated in consultation with our hematology colleague. And then obviously antiphospholipid antibodies, which can cause both venous and arterial thrombosis. Then there are monogenic etiologies. Cadocel, cerebral autosomal dominant arteriopathy, subcortical infarction, and leukoencephalopathy. As mentioned, if someone is presenting with history of migraine and cognitive decline and a family history of young stroke, then one should consider this possibility. These individuals present with subcortical strokes, dementia, mutation in the NOSH3 gene on chromosome 19, clinical history, MRI findings, and biopsy, which shows typical. So this is the MRI. You can see multiple subcortical infarcts, white changes, and then temporal lobes are classically involved in cadocel. And this is osmophilic granular deposition occurs. There is thickening of the smooth muscle valve, which goes on to completely obliterate the lumen. And here in electron microscopy, you see these osmophilic and granular material deposition, which is rather mnemonic for the cadocel. And then obviously there is genetic testing available as well for NOTC mutation to be noted. Another rare cause, which is autosomal recessive condition, similar to cadocel, and it involves the HTR one gene mutation occurs. Again, small vessels are predominantly affected, and there is no deposition of the osmophilic material in these individuals. They may present with premature baldness because it also affects the connective tissues. They may also cause lower back pain and disc prolapse in these individuals. Again, a very rare cause. Fabry's disease, again, is uncommon, but is treatable. It's a lysosomal inborn error due to galactosidase A deficiency and is X-linked. It may show angiokeratoma, so the skin lesions will be affected. And it is a multi-organ disease. Renal, kidneys, and heart is also involved in this particular condition. We would not usually screen for this unless there are clinical other signs to suspect this because of cost that is involved. Mitochondrial diseases like MELAS is another condition which may present with stroke-like episodes. They will have other features of mitochondrial abnormalities. One of the differential diagnosis obviously is mitochondrial disease if someone presenting with multiple stroke. But if you look at the MRI does not usually follow the imaging does not follow the vascular territory, so it may not be a run-of-the-mill type of vascular territory infarcts in these individuals. Other conditions include HHT, hereditary hemorrhagic telangiectasia. There are multiple genes that are affected. They present with bleeding abnormalities. Epistaxis is the most common, followed by GI. They can cause multiple telangiectatic lesions in skin and mucosa, and may involve CNS, liver, and AV malformation in the lungs, which may provide a paradoxical embolization for infectious or otherwise thrombi causing a stroke. These are some of the examples of telangiectatic lesions in the lips, in the finger, and on the tongue. Infectious causes, varicella zoster is one of the common ones, which may cause vasculopathy, and it can be delayed for a couple of years. Mean age from the time of skin rash causing stroke is 4 months. There should be high index of suspicion, and again, the detailed history is important to find out if there was any previous rash, especially if ophthalmic division is involved. It may cause a stroke. A CSF analysis and obviously vascular imaging is important, and treatment is usually antiviral therapy. Similarly, HIV, syphilis, those are other conditions. The treatment of HIV may lead to early atherosclerosis, and that would be a source of stroke. Bacterial infections, tuberculosis in developing countries, that may be a cause for basal vasculitis, or may cause direct invasion of the arteries as well. And similarly, other infection lead to stroke through either endocarditis, for example, causing an embolization, or vasculitic changes in the arteries. Pregnancy is associated with high risk of stroke, especially in the third trimester and in the puerperium, 12 weeks, highest in the first 6 weeks, because of the hypercoagulability, and may also lead to dissection. If it occurs during pregnancy, treatment with TPA is not contraindicated, although, as you know, that in most of the studies, or in all studies, pregnancies were excluded, but from personal experience from different centers around the world, a TPA is safe to be given to the patient, because the primary objective at the time is to save the mother's life. TPA is felt to not cross a placenta. For prophylaxis during pregnancy, low-dose aspirin is safe. If anticoagulation is indicated, then low molecular weight heparin would be used. So diagnostic approach. So it depends on a very detailed history. One should get a clear idea about the onset, evolution of the symptoms, what was the preceding illness, or if there was any, or trauma, detailed systemic inquiry about if there is a weight loss, systemic symptoms that the person has been experiencing, and also social history about the risk factors, smoking, recreational drug use, alcohol, for example, and a family history of young stroke. This is all very important. Examination. Obviously, one has to stabilize the patient first, take their vitals, and in addition to neurological examination, it is very important to look at their general appearance. Are there any skin lesions, for example, telangiectatic lesions, their stature, there are other abnormalities which may suggest mitochondrial abnormalities, skin laxity, hypermobility of the joints, which may suggest a connective tissue disorder, Marfan disease. Look at the eyes, for example, if someone has ptosis, meiosis, that may suggest dissection. So detailed examination is paramount. And these individuals look for signs of IV abuse, for example, if they've been using that. If someone is presenting with TIA, 6 symptoms are likely to suggest TIA: hemibody, weakness, or sensory deficit, monocular or hemivisual field abnormality, diplopia, or other associated ataxia, brainstem findings. And the symptoms which are less likely to suggest TIA would be scintillating, flashing, visual symptoms which may suggest migraine, symptoms which are of shorter duration, seizure at the onset, or if it is isolated syncope or pre-syncopal symptoms, postural dizziness, these are less likely to be a TIA symptoms. Flow blood panel count should be included, renal function, ECG, brain and vascular imaging, echocardiogram, Holter, and transcranial Doppler were indicated. Management of the TIA and stroke, there is no difference in the young adults and the old adults. Rapid assessment is paramount to diagnose TIA, initiate workup etiological workup. But the most important initial workup is obviously blood count and vascular imaging and brain imaging, because people can present, mimics can present with TI-like symptoms, and initiation of antiplatelet therapy and other secondary prevention intervention. For acute stroke, again, there is no difference, young or old adults, with respect to thrombolysis or mechanical thrombectomy. Just going over a few of the antiplatelet options, aspirin, clopidogrel, and a combination of aspirin and for the Agranox. I don't know whether that is being used or not. And then more recently, some newer antiplatelets. But the most common one that we are using are aspirin and clopidogrel. And there is place for dual antiplatelets after high-risk TI or minor stroke, if it is initiated within a short time of the onset of these symptoms. Two pivotal trials, CHANCE and POINT, which looked at aspirin clopidogrel combination versus monotherapy, and both showed that there was a significant benefit. In the POINT trial, the treatment was for 3 months, but further analysis has shown that I think you will realize the maximum benefit in the first 3 weeks. So usually 21 days of dual antiplatelets suffices. Now, one should be aware of clopidogrel efficacy and polymorphism, the mutation, which may lead to its loss of function, especially in the Asian population, because in the CHANCE trial, it was shown that there was those who carried this mutation had loss of function and did not respond well to clopidogrel. So sometimes we, in the Western countries here, someone who has been on aspirin, if they have failed that, we will switch to clopidogrel in those circumstances. Otherwise, if someone is presenting with TI or stroke and if they are already on a particular antiplatelets, it is not necessary to switch a person to a different antithrombotic therapy, but to look for the etiological factors, which other causes of stroke, and to look at whether they have been maximized with respect to their other vascular risk factors. If this is a cardioembolic source, atrial fibrillation is more common in the older population, but it may be also seen in the younger population, and for that, one would use anticoagulation and warfarin, or now the newer anticoagulants, the DOACs. Hypertension, as we all know, is the most important and modifiable risk factor. And in the low and middle income countries, it does it is responsible for almost 60% of the cases of cardiovascular events. And it is a silent disease, unfortunately, only diagnosed as far as the patient is concerned, and it has resulted in some end organ damage. According to the Canadian guidelines, blood pressure should be targeted to less than 1490 in post-stroke individuals without diabetes. But as you all know, some of the trials, SPRINT and ACCORD, have shown that a tighter target of can achieve sort of better stroke prevention outcome, and the significant numbers were noted, especially for a stroke. For in the diabetic individuals, 130 over 80 is the usual goal, less than that, or someone who has suffered from ICH as well. Now, obstructive sleep apnea is another risk factor for hypertension and stroke as well. And there is some association with hypertension too that has been noted, that people with sleep apnea may have blunted decline in nocturnal blood pressure. So you don't see that dipping that one would expect to see in normotensive people, or even primarily in the normotensive people, that you must have a dipping that is not seen. Because there is some evidence that perhaps hypoxia does lead to midnight surges in the blood pressure. So if someone is presenting with significant variability of their blood pressure on 24-hour monitoring and no dipping, if they have typical body habitus considered obstructive sleep apnea in these individuals. Cholesterol reduction has been shown to decrease risk significantly. And for every 1 millimole reduction in LDL, there is 11 less fewer major events per 1,000 treated stroke patients. So Canadian guidelines for dyslipidemia, we target the LDL to less than 1.8, and triglyceride, if it's more than 1.5, we may add icosapentine to this regime. Vasepa is the other name for that. And for diabetes, the Canadian recommendations are that A1C should be targeted to less than 7 and to less than 6.5 with type 2 diabetes, and it may be allowed a little higher in specific situations who may experience some other symptoms as a result of low blood sugar. Obesity, weight is another risk factor. In the Asian population, there are slight differences compared to Western countries. So moderate to high is noted in BMI of 23 to 27. And for 27 or over is considered high risk. So lifestyle recommendation must be given, healthy diet, regular physical activities, and cessation of smoking, drinking, and weight loss. Couple of slides with respect to carotid stenosis. It is categorized into mild, moderate, and severe. Severe degree of stenosis, if it is symptomatic, and arterectomy or stenting is recommended. For moderate stenosis in men, endarterectomy, if it is symptomatic, or stenting is recommended. Optimal medical treatment should be advised as far as female gender is concerned. However, endarterectomy or vascular revascularization may still be considered in those individuals of female gender, those who may have many other risk factors or they are considered at very high risk. And obviously the artery is symptomatic. Urgency of carotid endarterectomy, the maximum benefit that you realize is within the first 2 weeks, and the further you delay, then that benefit is lost. So the adopted sequential approach to etiological workup, it will depend on history examination and what is the high index of suspicion for a particular individual. So brain imaging, cardiac imaging is important. But if someone is presenting with dissection, then some of the other tests may not be needed. So it all depends on what is the history suggesting, what is the examination suggesting, that you look for infectious etiologies, inflammatory, malignant workup, and coagulopathies. In summary, young stroke is not rare. Socioeconomic and quality of life impacts are significant in young stroke because of the longer life that they could have lived with without stroke. Early recognition is paramount for a successful management. I will end there. I hope I did not run over time, and open it for the discussion or questions. Thank you.
Thank you very much, Dr. Khurshid Khan. If anybody who has a question, can you send in the chat, please?
All right. So I see multiple names. Is it from Syria and Turkey? Or
From Syria, Turkey, and Somalia.
Turkey and Somalia. Okay. And so how do you guys manage? So in Somalia, for example, what facilities do you have? Do you, I don't know if anyone is attending from Somalia. Do you thrombolyze there?
We are in North Syria. We start build stroke unit in Idlib Hospital, Center Idlib Hospital. And Somalia, I think that.
Okay. And in your experience, what are the main etiological causes or underlying risk factors or mechanism for stroke in your part of the world? Do you see a lot of infection-related strokes, or is it obesity or risk factors which are identified like hypertension or diabetes?
Well, almost we have as common risk factors: hypertension, arterial fibrillation, obesity, smoker. PFO is rare. Arrhythmia.
And do you see a lot of young strokes too?
As you see, Dr. Khorshid, every 10 stroke about one or 0.05 under one per 10.
Okay. Yeah, so we have been seeing a trend of younger strokes more and more. We are seeing young strokes here in the Western countries.
Assalamu alaikum. My name is Dr. Ibrahim Abdullah. Could you hear me?
Assalam. Yes, Abdullah. Ibrahim?
Yes, Dr. Abdullah.
My name is Dr. Ibrahim Abdullah from Somalia, Simad University. Right now I'm working with the ICU with Dr. Sumail Hospital as a GP doctor. First of all, I'm thanking the professor to give us our fruitful lecture for that stroke. In terms of my 1 year staying in our ICU in Somalia, wallahi, we don't have any much resource like thrombolytic kida or with the device that you said in terms of management. But if I start about the more cases that we see in our ICU, more likely is more in ischemic stroke, according to the hemorrhagic stroke. The risk factors that we saw in our history in the patient is more in hypertension, smoking, hyperlipidemia. Yeah, that's the more risk factor that can cause this stroke.
That's right. Yes, this division of young and old may vary from different regions of the world, right? Because
okay, in terms of our male and female, we saw about more in the male. In terms for the age, still we don't see about the less than almost about 30 years. We only see about more than 30 years, almost 40, 60, 50, like that. Still we don't see about young patient with stroke.
okay. So it's more common in men than female.
Yeah.
Yeah. Yeah, so that is more or less the same trend here as well. In the Western countries, in female gender, because of their childbearing age, they may be on contraceptive therapies and pregnancy. So that's why in that young age group, they may be the same, but some of the lifestyle that you refer to may be much higher. The incidence, the prevalence may be higher in men. So then it sort of balances out. So as I show you the graph that until the age of 35, 40, they are more or less going parallel or overlapping each other. And after that, it sort of separates. And then at a later time, when the older age, especially in the Western countries, because female life expectancy is higher and they live longer, then there is a slight increase in the female gender. Yeah.
May I ask a question, Dr. Ahmed?
Yes, go ahead.
Assalamu alaikum. I'm Dr. Saima. I'm from Pakistan. I'm interventional neuroradiologist there.
Nice seeing you, Dr. Sam Ahmed.
Thank you. Sir, we have a question here in the it's in the question and answer box. It's from one of the attendees. So it's, can we say that the strokes are more dangerous in young people than elderly because of the collateral circulation in the affected area?
Yeah, so that's a good question. And we do see young patients, and you would think that people who have had older people, there may be some atherosclerotic disease, there would be some stenotic abnormalities, and they would have better collateral over time. But in practice, we don't see that that often. So, I mean, there is no clear-cut sort of, I can't give you a number that, oh yes, that in younger individuals, there is always going to be a bad outcome versus older outcomes, because sometimes we see a very good collateralization, because collateral circulation kicks in as soon as there is occlusion of the major large vessel, right? So we have seen both scenarios where there is very poor collateral flow in the younger individuals and very good collateral flow as well as in the elderly population. But intuitively, you would think that perhaps that should be the other way around, that in older people, you would have better collateral flow because of atherosclerotic disease that has been going on for some time. But at least anecdotally, I don't see that. We often pose this question to ourselves as well.
Thank you. So I have few questions from my side because we have no questions in this question answer box.
I have a question.
Okay. You have a question?
Yes, I have a question.
Okay. Go ahead.
Again, assalamu alaikum. My name is Dr. Ibrahim. The question that I have is, the patient bring in the hospital with loss of conscious. At that moment, I don't have with CT scan is available. So if my question is, can I clinically differentiate with ischemic and the hemorrhagic stroke in the clinical, according with history and according with examination?
No, you cannot. I mean, you can surmise that, okay, the symptoms, if they were reversible, like the TIA type of symptoms, the chances are this may be ischemic. But when it comes to someone who is having persistent symptoms, we cannot differentiate that. Yes, more often than not, we say that, okay, other associated symptoms, for example, headache or very high blood pressure, may suggest that there might be hemorrhage, but we cannot use that those features to decide if, let's say, you had the opportunity to give someone lytic therapy, you won't be able to do that. No, you have to have the imaging done to rule that out.
Thank you.
So any other question? Dr. Ahmed?
Yeah, I have a question.
Okay, go ahead.
Firstly, I'm thanking to Khurshid Khan and other organizer team. I am from Somalia. My name is Dr. Abdullahi from Sim University. I'm GB doctor. I'm asking you, Tore, in pregnancy, some patients they develop, cerebral venous thrombosis, CVT. How can I differentiate CVT from stroke in the postpartum period or third trimester?
So you're talking about cerebral venous thrombosis?
Yeah. How can I differentiate from the arterial stroke?
Yeah, so that is through the imaging. Imaging, because both of them can cause focal neurological symptoms, which could be because the cerebral venous sinus thrombosis can cause ischemic stroke as well, a hemorrhage as well, because of the back pressure, right? Increase. So the way to differentiate is through imaging and not through just a clinical examination.
There is a difference on clinical between them.
Yeah, so CVS, they often present cerebral venous sinus thrombosis with headache. So that would be one of the clinical features that may, point to that fact that this may be due to something more than just ischemic, but at the same time, ischemic stroke can also cause headache. So those are not the features that can help you just differentiate on the basis of on the clinical features basis. Because both can cause headache, both can cause focal neurological symptoms. So you have to have the imaging. Does that answer your question?
Thank you, Dr. Khurshid Khan. We haven't any more question in the chat.
So
Any questions? Is that what you said in the chat? I don't see that. Are there, Dr. Ahmed, Sam Ahmed?
I think we are already ahead of time. So I think we should close it now because it's already more than 1 hour.
All right.
Khurshid, I'm just getting in. Thank you very, very much for coming over. The one who doesn't know Dr. Khan, I know him for over 25 years now. He's my mentor.
Astaghfirullah. Thank you, Maher, and everyone else for putting up for 1 hour. And
Dr. Khan, the lecture will be recorded and it will be posted. So for the people who could not attend for some reasons, they can go back and attend, inshallah.
And sorry, there was some confusion. I thought it was going to start at 10. So anyways, I'm on call. I was giving a TPA to a patient in the ED. All right. Thank you very much.
Excellent.
Thank you. Thank you so much.
Dr. Ahmed, Mutlaq, you already gave the Arabic sessions?
Yeah, with you, Dr. Maher.
Wonderful. I'm sorry, I have to interrupt it just for patients to see. But Jazakumullah khair, everyone for...
Hello?
Let me see, how can I get out of this?
Hello?
السلام عليكم. بس رح نعطي ملخص صغير. أول شيء بنشكر الدكتور خورشيد خان على المعلومات القيمة، وبس رح نعطي ملخص صغير إن شاء الله ما نكثر عليكم. طبعا الاحتشاءات عند الشباب طبعا بالدول المنخفضة الدخل والمتوسط الدخل حدوث الاحتشاءات الدماغية عندهم أكثر من الدول المتطورة. طبعا الاحتشاءات الباكرة هي من عمر 20 ل 64 سنة. بسنة 2010 كان 5.2 مليون احتشاء في هذه الأعمار. طبعا الحدوث من 7 ل 15 كل 100,000. عند الأطفال من 2 ل 6 كل 100,000. طبعا الإنذار ارتفاع معدل الإعاقة بعد الاحتشاءات، ممكن تكون الإعاقة اضطرابات معرفي، اكتئاب، قلق، اختلاجات. طبعا التكلفة بالعلاج والتأمين أكثر من 6 مرات من المرضى الكبيرين بالعمر. 11% ممكن تتطور اختلاجات عند بعد الستروكات خلال 9 سنوات. طبعا التحديات مع التشخيص، تشاخيص تفريقية بتكون كتيرة عند الشباب، وفي مقلدات الاحتشاءات، منها الاختلاجات، منها انتهانات الجمل العصبي المركزي الشقيقة، وأحيانا الأورام الدماغية ممكن تغيب أو تشابه الستروك. أنواع الستروكات عند مرضى كبيرين بالعمر الإقفاري بتكون 80%، النزفة 20%. أما باحتشاءات بالستروكات عند الشباب 50% بتكون إقفاري، 20% نزفة، و30% بتكون نزف تحت العنكبوت. التوزع العمري بين 20 و 24 سنة 2.4 لكل 100,000 شخص، 30 ل 34 بيكون 4.5 ل 100,000 شخص، من 45 ل 49 تقريبا 32 لكل 100,000 شخص. طبعا نحن بنحكي عن عوامل الخطورة. في عوامل الخطورة العادية هي الضغط، السكر، اضطرابات الشحوم، التدخين، الأمراض الإكليلية والبداني. وفي اضطرابات الأوعية. اضطرابات الأوعية غير المصلبة مثل التسلخ، موية، التهابات الأوعية، اعتلال الأوعية، واعتلال الدماغ خلفي العكوس. وفي اضطرابات الأوعية المصلبة. على التسلخ، تسلخ الحدوث من 20 ل 25%. غالبا بيكون يعني الأشيع هو الشريان السباتي قبل 2 سنتيمتر من التفرع على مستوى الفقرة الرقبي الثالثي والثاني، الشريان الفقري على مستوى الفقرة الرقبي الأولى والثاني. الأسباب التسلخ ممكن تكون عفوي، ممكن رضي، ممكن تكون اضطرابات النسيج، إهلر دانيلسون أو مارفان. العلاج إذا مو جراحي ممكن تكون أسبرين أو كلوبيد لمدة 3 إلى 6 أشهر. عسر التصنع الليفي العضلي، أشعة بتكون بالشرايين الكلوي 75%، وممكن تكون بالشرايين الفقرية 25%. ممكن يؤدي لاحتشاءات، ممكن يؤدي إلى نزوف. داء موية هو ترجمته هو نفث الدخان. بتكون يعني تضيقات في الفروع النهائية من الشرايين، ممكن تؤدي إلى نشبات إقفارية أو نزفية أو TIA أو نزف تحت عنكبوت. ممكن تكون من أسباب الستروكات هي الأدوية، الكوكايين والأمفيتامين والهيروين، بتؤدي إلى احتشاءات ولا نزف. طبعا غالبا بتكون الاحتشاءات بعد 6 ل 24 ساعة بعد التعاطي. التهاب الأوعية ممكن تكون أمراض إنتانية، تاكاياسو، كوازاكي. التهاب الأوعية محرض بالأدوية. طبعا الاستقصاءات التهابات الأوعية ممكن نستقصي الشيء الإنتاني والفيروسي، الأنا RF، DS DNA، الC3 C4 CRB ASR، اختبارات الكبد والسفلس والإيدز. الاعتلال الدماغ الخلفي العكوس بيأتي بالأعمار المتوسطة، الإناث أكثر من الذكور. أعراضه بتكون صداع حادي. الأمور المحرضة بتكون الحمل. علاجه ممكن يكون نيموديبين أو فيراباميل. الإنذار جيد. الداء المنجلي ممكن يؤدي إلى تطور انسداد بالأوعية الكبيرة بالدماغ، ويؤدي لنشبات إقفاري كمان. الأسباب القلبية اللي بتؤدي للستروكات: اللانظميات، اعتلال العضلة القلبية، الفتحة بين الأذينين، التهاب الشغاف، الأورام القلبية، الأمراض القلبية الخلقية. الفتحة بين الأذينين انتشار 25%. التشخيص غالبا بيكون هو بإيكو القلب، اختبار الفقاعة والسيروم المهيج، ممكن يكون إغلاق جراحي. في داء فرط الخساري، طبعا اضطراب الخساري بيكون اضطراب في بروتين سي واس وعامل لايدين والانتي ترومبين الثالث والجي 2021. في المكتسب هي بتكون فرط الخسارية المكتسبة اللي بتجي بعد السرطانات أو الأدوية الهرمونات. في الأمراض الاستقلابية الجدازيل والكراسيل. الجدازيل هي شقيقة واضطراب سلوكي واحتشاءات تحت خشبي. الكراسيل بتكون تقريبا مثل، بس بيكون إنه وحدة نمط راجح وحدة متدني. الستروك والحمل طبعا كل من 30 ل 100 ألف نسبة الاحتشاءات بتكون بالحمل. طبعا بتكون بالثلث الثالث أشعة شيء وبالأسبوع 12 بعد الحمل. طبعا العلاج بده يكون كليكسان وارفارين بعد الأسبوع 12. طبعا بيكون استطواب الوارفارين مطلق مثل الصمام، تركيب الصمام. هلا بالنسبة لعوامل الخطورة رح نحكي عليهم بشكل مختصر. ضبط الضغط بالمرحلة الحادة بين 16 و 18. بعد المرحلة الحادة ضبط الضغط بده يكون تحت الضغط الهدف تحت ال 14. السكر الخضاب الجلوكوزي بينضبط عند المرضى الطبيعيين أقل من 6.5، عند مرضى السكريين أقل من 7. اضطراب الشحوم ينصح بالستاتين في كل الستروكات. التدخين تقليله أو قطعه يساعد في تقليل عوامل الخطورة. البداني حكى الدكتور عن BMI، ينصح بتغيير نمط الحياة وتخفيف الوزن. BMI يكون تحت 24. وحكى عن علاج الستروك الحاد لل 4 ساعات ونص بيكون تطبيق DNK، وبعدها لل 24 ساعة ممكن يكون تداخلات. وبعد الوقاية السنوية بتكون أسبرين كلوبيد لمدة 21 يوم. ممكن الأسبرين أو الكلوبيد يتابع فيه.